Hélio.
Olá, boa noite a todos. Meu nome é Hélio Rubens de Oliveira Filho, sou médico mastologista, um dos cofundadores do portal Câncer de Mama Brasil. Estou aqui juntamente com meu amigo Felipe Zerwes, que também é cofundador do portal Câncer de Mama Brasil. Gostaríamos de agradecer muito a presença de todos vocês para mais uma live nossa. Agradecer especialmente a presença dos dois ilustres palestrantes, Dr. Andrea Barrio, from New York, Memorial Sloan Kettering Cancer Center, e Dr. A.Rosa, atual presidente da Sociedade Brasileira de Radioterapia, from New York, diretor e Dr. A.Rosa, diretor da radioterapia do Grupo Clínicas Brasil, e campeão de basquete pela Bahia em 1990, não é isso, Arthur? O que a gente vai fazer hoje? A gente vai começar falando um pouco sobre a pandemia do Covid-19, quais são as mudanças que ocorreram em Nova York devido a isso, principalmente na conduta dos pacientes com câncer de mama. E depois com o Dr. Arthur, qual é o posicionamento da Sociedade Brasileira de Radioterapia e a conduta dos pacientes com câncer de mama. E depois com o Dr. Arthur, qual é o posicionamento da Sociedade. A gente vai tentar o foco.
Hélio, só, desculpa. Tu tá com a janela do YouTube aberto?
Não, tá fechado
no YouTube.
Já fechei.
Hélio, só, desculpa. Tu tá com a janela do YouTube aberto?
É o teu microfone, Felipe, desliga aí. Fechei. E o que acontece? A gente vai falar, então, sobre esses dois temas. Depois a gente vai falar sobre a conduta da axila pós-tratamento neoadjuvante, seja quimioterapia ou seja hormonioterapia, do ponto de vista dos principais centros de referência do mundo, que é o Memorial Sloan Kettering de Nova York, e do ponto de vista radioterápico com o Dr. Arthur Rosa. A gente vai deixar o chat aberto para perguntas. Vocês podem fazer pergunta em português ou em inglês. Vamos tentar responder todas, não posso garantir. E eu vou estar cuidando disso. Enquanto isso, o Dr. Felipe vai estar conduzindo a conversa com o Dr. André, com o Dr. Arthur. Dr. Andrea Barrio, thank you very much for being with us. It was a great pleasure, a very great honor for us that you are here with us. Dr. Arthur Rosa, thank you very much for being with us. So let's start. Felipe, please.
Ok, Hélio, obrigado. Andrea, Arthur, thank you very much. I'd like to emphasize our pleasure and our honor to have you here with us tonight. From now on, we are going to speak in English. I'd like to ask you a favor, Andrea. We don't have simultaneous translation, so you could please speak slowly. Unless you have improved your Portuguese skills on the last week, so we can talk in Portuguese. What you tell me? Silly joke. Well, the main subject of our conversation tonight is axillary management after neoadjuvant treatment. But we'd like to start with a brief summary of how we are dealing with COVID-19. I have just saw the John Hopkins COVID Resource Center, and New York State has today 27,000 deaths for COVID. Mm-hmm. It's more than twice the number of Brazil. We have more or less 12,000 deaths because of the COVID. So how are you dealing with it, Andrea? What are you doing to make Memorial a safe hospital for your patients? You are testing your patients. You are testing the staff. Has you changed your protocols? We have a lot of guidelines, international guidelines, suggesting to postpone surgery in luminal cases, for instance. Mm-hmm. What have you done in Memorial these days?
So New York was badly affected. We saw a huge number of cases that started at the beginning of March with a very quick increase in the number of cases, so much so that most of the hospitals were overwhelmed. But Memorial is a little bit different than the other hospitals in New York because we are not a 911 center. So we do not receive patients who come in just saying, I have an emergency, coming to our center. We did, however, accept those patients that came from other hospitals if other hospitals were overrun or could not take care of patients with cancer because they had so many COVID patients. So at the peak, we had a little over 100 patients in the hospital with about 30 in the ICU, and those numbers have declined significantly. So we don't have nearly as much now. So what we had to do was reduce our surgical volume for two reasons. One, because we didn't have the staff. They were redeployed and they had to go work and take care of the COVID patients. And we didn't have personal protective equipment either. So we had a massive shortage of gowns and masks. And we didn't want to use the protective equipment for elective cases when they should be used to take care of COVID patients. So we took about a 75% reduction in our surgical volume. We stopped operating on all benign cases. So patients with atypia of any kind were asked to be postponed. That then went to DCIS. We stopped operating on DCIS. And then we stopped operating on postmenopausal luminal A cancers. And any postmenopausal patient in general that was felt to be sick or had significant comorbidities where if the COVID would make them very ill, we did not treat them. We have converted almost all of our visits to telephone visits now. So all of the new visits we see are initially screened with like a telehealth visit, kind of like we're doing now over the camera, over video. And then if they want to have surgery, we talk about the next steps. Our ORs have opened up though. So as the cases in New York have declined, which they have rapidly, we opened up the ORs to the premenopausal luminal A, to the DCIS, and now to the atypias. And I still have avoided doing the postmenopausal patients. I have several of them that I'm waiting because I worry what would happen to them if they got COVID, because I think that's worse than treating those patients with hormone therapy. So the ER positive luminal A's, we put on endocrine therapy. My DCIS patients, I offered endocrine therapy, although I did not require it. And also the same with the atypias. If they were very anxious, we offered them tamoxifen and even low dose tamoxifen or baby tam, 5 milligrams. But I've now operated on almost all of them except for the postmenopausal patients. We do require COVID screening, and that's New York State. Governor Cuomo requires it 48 hours before surgery. They have to get tested and negative. If they're positive, their surgery is delayed until they're asymptomatic. And if they're asymptomatic already, we wait at least 2 to 3 weeks. And all patients before a needle biopsy, also anybody who's having any type of procedure gets COVID screened and has to have a negative test. We don't allow any visitors in the clinic, in the operating room. All these patients have to come alone and they get dropped off, which is really hard for them, especially if they're having mastectomy and they have to stay overnight. And they haven't started routinely screening the staff, although they're going to start. I am getting mine tomorrow. I've already been tested once and negative, but we're going to start weekly screening, and they're going to start testing us for antibodies too. So I get my tests tomorrow just to see who's been affected.
Thank you. 75% less volume of surgery.
Yeah.
That's a lot. It's
a lot. Yeah.
I hope you can return it very soon.
Yeah. I mean, yeah.
I just have one question.
Yeah.
Arthur, please.
Yes. So I have one question myself. Andrea, how long does it take from the time that you guys stop scheduling surgeries to the time that you start scheduling them back again? I mean, the rise of the peak of the infection, and how long does it take? How was this time?
It was about 4 weeks.
4 weeks.
For us. Yeah. I think we went about 4 weeks not operating on DCIS. And the older postmenopausal luminal A patients, I have them, I'm not seeing them again until June or July. I worry more about them, the smokers, the diabetics, the hypertensives. I don't see any harm in waiting a little bit longer for those patients.
Did you use hormone therapy in any premenopause woman?
I did. Well, not really. I had one that we were told we couldn't do the cases, but we were only on hold for premenopausal luminal A for about 10 days. So we started her, and she wasn't on for very long before I was able to do her case.
Perfect.
Yeah.
Okay. And in Memorial Sloan, you usually see early stage breast cancer patients. And do you think that doing that, you start to see more late stage breast cancer, or do you think that what you are doing can handle that?
That's what I worry about. We shut down our own screening program, and it's still shut down. It should open up next week, but nobody's doing screening mammography right now. So the only patients I'm seeing right now are palpable lumps or patients with locally advanced cancer. And that's only because they're symptomatic getting tested. But I worry that now we're going to see these delays, and now we're going to see more patients with lumps. And I think even when we open up, people are afraid to go get screened. They're afraid to go out and go see the doctor. We're seeing this now in New York hospitals, where some of my colleagues tell me that patients have bad gallbladder cholecystitis or chest pain or other things, and they won't go to the hospital because they're so afraid of contracting COVID. So I worry that it's going to take a while before we see people actually feel comfortable enough to get mammography again.
We are put all these patients on a huge dam. When it blows, I don't know what's going to happen.
I know.
Yeah.
I know.
Artur, what has changed in radiotherapy protocols around the world and in Brazil?
Yeah.
Are you delaying treatment as well?
Yeah, the funny thing here in Brazil is that we are kind of using the previous experience in other countries, especially Italy, France, Spain, and the pandemic impression that people had in New York City. In Brazil, we are a very, very big country, as you know. We can fit Europe inside Brazil. So trying to have only one strategy for different regions kind of very complicated. And we indeed have an increasing number of cases in Rio and Sao Paulo, and in some parts of the North and Northeast, where the healthcare infrastructure is kind of full, but we don't know if this is because of the COVID or if the bad infrastructure was there already. So we've been doing some strategies in the radiotherapy departments. Brazil has only half of the machines that we need. So we do have some places in the public services where there are lines for treatment. And these places were not badly affected because there's still a need for radiation therapy, even with the fear of COVID. So the department's kind of still busy right now in some places. Even with patients that are referred to the department because they can get surgery, like head and neck cases, early stage head and neck cases, prostate cancer. So they can have surgery, so they got referred to radiation therapy. But we are implementing some strategies to make the environment more safe. So there's a previous triage by phone to see if the patients are at risk to come to the department, either with fever or respiratory symptoms. We are putting more space between treatments. So the treatment slots that usually are 10 or 12 minutes long, so they're being increased to 15 minutes, even 20 minutes if in more complex treatments. The hygiene between treatments it's somehow increased, so we are taking much more care. Also using personal protective equipment in the staff. There was a very, very interesting case in Brazil when the pandemic was decreed back in February to March. There is a radiation therapy department in Rio where one of the physicists he was on vacation in New York City, so he came back and they threw a welcome party to him when he got back in Rio. And he was already with some minor respiratory symptoms and got positive for COVID. So there was no access for testing at that time, and they put the whole department on quarantine. So the department was closed for 12 days. And all of the patients were with no treatment for that period. So I think the main fear right now is not to have patients tested positive. So if they test positive, they can be scheduled for a contingency time. But the main fear is to have the staff tested positive. So with shortage of staff, we can jeopardize the access to treatment. I work in Salvador, which is a city in the Northeast. Andrea was here, and we've been facing maybe 40% decrease in the patient referral. But so far, we didn't have any positive COVID-19 patient. And despite some respiratory symptoms, the staff was tested and no COVID-19 positive staff so far. I'm not sure if it's going to last long. We'll probably face some positive tests very soon, since the number of patients, positive patients, is increasing here. But because of the shortage of patients, we've been handling the department very safely so far.
Hélio, do you have any questions about COVID for Andrea and Artur from the audience?
Perfect. I have a question from Guilherme Novita. Andrea, did you have any COVID-19 infection after surgery related to the recovery of the patients?
So I have not personally had a patient who tested positive, but I have had a couple of my colleagues where the patient tested negative and then a day or two later developed infection, not because she acquired it in the hospital. We haven't really seen very many what we call nosocomial infections where they're getting it from the hospital. But she had it, and there's a false negative rate to the test, maybe not because of the way the PCR is done, but because of the way the swab is done if they don't get far enough back to do the swab. If you haven't had that test, it's entirely unpleasant. It's like a brain biopsy, but they have to get really far back, and so you can have that. And so we in the operating room, when they intubate the patient, I wear an N95 mask the entire time. I never take it off in the operating room, which is difficult, but in case the patient does have a false negative, we wear the mask, and the rest of the staff who's not wearing it leaves during intubation. And then when they extubate the patient, everyone leaves the room, and then we have to wait 20 minutes before anyone can enter the room after extubation to let the air filter out of the room. But the real fear is that, like the study from China in Wuhan, is that if you have a positive patient, that they can have a bad outcome and a high mortality. We have not seen that, thankfully, with our own patients, and very few have become positive after surgery.
Perfect. Thank you very much. I have another question from our colleague from São Paulo, André Matar. It's not related to the COVID-19, but how do you deal with your breast cancer patients in memorial? And do you use oncotype in the neoadjuvant setting?
That's a loaded question. We do not yet, but I think that's coming. And I think it's coming because when we see the results of our exponder, if we find that oncotype is predictive of a response to chemotherapy in node-positive patients that are ER-positive, it'll make us question whether all node-positive, ER-positive patients need chemotherapy. And that might be a situation where we would begin to use Oncotype to help determine which neoadjuvant patients should get chemotherapy or endocrine therapy, but we don't routinely use it now.
Perfect.
Do you have any breaking news for us about the ERA exponer?
I do not.
No?
I have no breaking news about that.
Okay.
And I have just one more question. If you change how you deal with patients in the pandemic, it was done by Isabel Albuquerque. What about reconstruction? What is the current orientation? Are you postpone or doing the same moment of the surgery?
So we stopped doing flaps completely.
Okay.
We do no autologous reconstruction right now, and we haven't for about 6 weeks. It's the one scenario where our plastic surgeons feel that the risk of the surgery and the potential if they get COVID and having a bad outcome is too high. So all of the patients who want to have a flap are getting a tissue expander. We're still doing tissue expanders for those patients, but we're not doing autologous reconstruction right now. I don't know when that program will start again.
Perfect. Thank you.
Mhm.
So we can move on, Felipe. Yes.
Yeah, anything else from COVID? So you can go to the main subject.
I have one more question from Andre Mata.
I also have a question here about the radiation oncology department at Memorial Sloan Kettering Cancer Center. So do you guys have any news about that? Are they organizing some different strategies to receive the patients?
So they have something in press right now to talk about what they've done, but we have completely changed our strategies. So they didn't want, like you said, the number of patients coming in that were coming in before, because they were coming in every 15 minutes and we can't have that number of patients in the waiting area. We do what you do also. We send them a questionnaire the day before about their symptoms, and then the next day they have to fill it out. And when they come into the clinic, they all get their temperature taken as well. The staff has to fill out that same questionnaire every day. So the DCIS patients, we were already doing this before, low to intermediate grade, over 50, less than 2.5 centimeters, no RT. If they're willing to take endocrine therapy. The luminal A ER positive patients, early stage, node negative, delay of up to 20 weeks, which they think is safe based on data. So we have some patients waiting up to 20 weeks for RT. When they get whole breast radiation, they're doing it like the UK, the Fast Forward trial. 5 treatments with 2 treatments for boost, so 7 total treatments of 26 gray. And then the over 70 population, the same, omission of RT in stage 1 luminal A node negative cancer. The other patients are typically getting treated the same way, the node positive, the patients who either post-lumpectomy or PMRT, but they're triaging them. So the delays come depending on your level of risk. So inflammatory breast cancer, node positive, ER negative cancer after neoadjuvant chemotherapy, they get treated in the normal fashion. And then the other patients can have, 12-week delays, 16-week delays, 20-week delays, depending on their level of risk.
Do you think that this strategy is just in New York City or in other parts of maybe Montana or Idaho? Are they doing the same?
I think they're running around crazy in Montana and Idaho. I don't know. This is our policy and they're writing it up actually. I think it should, I have the manuscript. It's, I don't even know if I'm allowed to say that, but it's in press, I think, and should be out soon, which is our protocol for managing radiation in these patients.
Andrea,
yeah.
Do you have, in your perspective, after the COVID-19, do you think that we're going to see a rise of omission of radiotherapy in these elderly patients?
I think we're going to see some de-escalation. I think that's been a long time coming, though. I think that if we look at kind of national, like the SEER database and other database, NCDB, I think these patients are getting overtreated.
Why do you think, Arthur?
What's that?
Yeah.
I think
Prime
we're gonna,
1, the Prime 2, the randomized studies.
yes, I think we're gonna have so many paradigm shifts in everything, in surgery, in the way that we buy coffee at the Starbucks, and things are gonna be very, very different. And what I think that there might change the approach of radiation for breast cancer at all. I mean, these hypofractionation schedules, they're gonna come to stay. And I think accelerated partial breast irradiation is gonna get a much larger part of the indications after this pandemic. So I'm not sure if we're gonna go and treat less with radiation, but I think we're gonna at least make more appropriate approaches, since they are gonna be accepted as safety approaches. Usually we need 10, 15 years to say that this or that strategy is safe or not, but with this acceleration of interpretation of results, I think we're gonna incorporate much different approaches in the day-to-day treatment. So it's just a feeling, but I think that a multidisciplinary approach needs to be fortified as the right approach for breast cancer. We're seeing that already, but I think with all this new information, it needs to be a thing to be done every day for every case.
Perfect. Can you move on?
I have just one more question from Francisco Pimentel to Arthur. Do you have some data to show us about the delay in radiotherapy in the adjuvant setting?
Yeah, I think if we were a scientific country, we're gonna have much data like 10 years ago, when with the shortage of access in radiation oncology, we received patients with over 6 months of surgery. Like the regular patient who came to our department at the public hospitals were at least with 5 to 6 months from surgery. And the thing is, we don't have data on that, but usually the relapse rate at that time was not higher than usually we see in the literature. So usually there are some friends some colleagues that say that if you don't have a relapse in 6 to 12 months, it's not going to happen. This is not what literature shows, that we can have late relapses. So I think this 5 to 6 months time is quite safe, but we have to put in perspective that the high risk patients, like node positive, closed margins, age, I don't think it's itself just by itself it's a high risk profile. But I think 5 to 6 months is quite safe by personal experience. I'm not sure if Andrea agree with me with that.
Yeah, I mean, that's what they think in the low risk luminal A type patients, that there is evidence that a delay of up to 20 weeks does not result in decreased or increased rates of local regional recurrence. But again, it has to be the low risk patient. It can't be your node positive, triple negative patient that we're talking about.
Yeah, the thing is that we are dealing with microscopic risk, so cells that are left behind with potential risk for duplication. And since the risk is microscopic and we don't have the tumor like duplicating by itself, this strategy to think about the delay safe is somehow appropriate.
And we've been employing endocrine therapy during that delay period. So again, these are ER positive patients, so we give them endocrine therapy while they're waiting.
Can we move on for axilla manejado?
I just have one thing to tell before we move on. I just want to gostaria de pedir para todas as pessoas que estão assistindo a gente que curtam o nosso canal e curtam a página do Facebook e ativem o sininho ali para receber notificações. Thank you.
Do you want to answer that, Andrea?
I'm okay.
Just to like our website, Andrea. Thank you.
Yeah.
Andrea, how are you dealing with neoadjuvant chemotherapy? Let's start with chemotherapy, then we can choose to talk about hormonal therapy. You have just told us outside the chat that you don't used to do too much neoadjuvant endocrine treatment.
Yeah.
How do you look at axilla? Do you search by ultrasound? Do you clip your lymph nodes prior to the chemotherapy? What do you do?
So we have traditionally evaluated the axilla by just physical exam. I mean, that's kind of, it's the same method in Z11. They did not use axillary ultrasound routinely. We do palpation, but we see a lot of patients who come to us with an axillary ultrasound, right? So they've already had it. About half of them do. And I can't say I never use axillary ultrasound. If I have a patient where I'm searching for an indication to give them neoadjuvant chemotherapy, like a HER2 positive patient who might need a mastectomy, where I don't want to do an axillary dissection, I don't want to find a positive node, I'll do an axillary ultrasound because I know that will help her in the long run to do less surgery if I can do neoadjuvant chemotherapy. So we routinely just do palpation, and we ascribe them as clinically node negative if they do not have palpable lymph nodes on exam. If they come to us with an abnormal ultrasound and they're clinically node negative, I typically will not pursue that because if they're going to have a lumpectomy, they're going to be managed according to Z11 anyway, where it will take 3 positive nodes for me to do an axillary dissection. If my radiologist says there's multiple abnormal nodes here that I'm seeing on ultrasound that someone had outside, I think I will pursue that, but it's a conversation. So typically, again, clinically node negative by exam is how we do it. But if there's something really abnormal by imaging that they're seeing, I will talk to the radiologist and discuss how we should pursue it.
Okay, but when you are thinking about neoadjuvant treatment, like triple negative disease, you have just said, you perform the ultrasound?
No.
To orient Arthur to the radiotherapy, you don't perform ultrasound even when you are thinking in neoadjuvant therapy? No?
Not if I already have an indication for neoadjuvant chemotherapy. So our indications for neoadjuvant chemotherapy are stage 2 HER2 positive and triple negative breast cancer. So that's either a tumor 2 centimeters and above or a palpable lymph node that's positive, biopsy proven positive. Otherwise, in the stage 1 or in the ER positive patients, I'm definitely not looking for a reason to give them neoadjuvant chemotherapy. So if they're clinically node positive by exam, then we biopsy the node.
Arthur, you correct me if I'm wrong. The Astro doesn't recommend ultrasound evaluation prior to chemotherapy to better select patients from radiotherapy. I don't want to be a...
Yeah, the thing is, usually the information about a positive node, it's very important to address the treatment volume. So if you have a positive node, even with a clinical negative axilla, alongside with other high-risk features, you can think about to go for some like larger volumes of treatment, supraclav, and even the whole axilla after a neoadjuvant treatment. So as much information you give me, as better I will address the treatment volumes for treatment. So one of the things that we might criticize in most of the radiotherapy, breast cancer radiotherapy papers is that the volumes that are treated, they're not well explained. And even if you do have an explanation of which volumes were treated, those distribution is somehow complicated. For instance, just the old papers, the old radiotherapy strategies. When you say that you treated the axilla, you had a posterior axillary boost. The posterior axillary boost was a field that you used to compensate the dose in the midline. So with a anterior posterior field, you had at least 35 to 40% variation in the dose. So if you're prescribing 50 gray, on the maximum build-up dose, build-up point, you had at least 40% less dose in the midline. So if you understand that the axilla was at risk, you compensated those with an extra posterior field just to make sure that the whole area was receiving the same dose. So you don't have this well explained in the paper. So somehow the results of the treatment might be influenced for the kind of radiation therapy that you gave to the patient, and we still have doubts in the new papers, even the Z11 or the Mars trial. So they show the field design, but the dose distribution, we have to assume that they were homogeneous. I mean, this is very, very complicated. So bottom line about all this technical thing, as much information as the breast surgeon gives to the radiotherapy department, as safer will be the treatment coverage of the high-risk volumes.
Andrea, a practical question. You have a negative axilla and this patient go to neoadjuvant treatment. For instance, a triple negative breast cancer. When you perform the axillary surgery, do you have any concern about dual tracer or took at least 3 lymph nodes like you do on the positive axilla, or no?
So
you get
the
it?
prior meta-analysis, the prior meta-analysis that looked at clinically node-negative patients and the use of sentinel node biopsy didn't require dual tracer mapping. They didn't see a difference in identification rate or outcomes. But at Memorial, we do dual tracer mapping for all patients after neoadjuvant chemotherapy. It's just our requirement to increase our identification rate. But in the clinically node-negative setting, we do not have a requirement to get 3 or more nodes. We just, we can map and then just get however many nodes we get. It doesn't matter.
Andrea, how about radiotherapy volumes? Do they treat, for all patients that have neoadjuvant chemotherapy, like just for instance, a T2 N0, clinical N0 patient, 41 years old with neoadjuvant treatment. So would they give radiation for the supraclav node or?
Not typically. Don't quote me. I'm not a radiation oncologist, but not if there's no treatment effect in the nodes and no evidence that that node was ever positive, then typically they're not treating the nodal fields.
But what if they have only one positive sentinel node and no other nodes in your sentinel node biopsy? Do you go for dissection or for all cases?
All cases. Right now. I mean, I can't say that's true for every single person. We have patients who have, or some attendings who've not done that. But right now, until the Alliance trial gets published, we are dissecting patients with any volume of disease in the axilla after neoadjuvant chemotherapy.
Are you enrolling patients?
Let me get a hook on that.
What's that?
Even when you do endocrine neoadjuvant therapy?
We don't have a good policy. Neoadjuvant endocrine therapy is
very king, yeah.
I kind of say that that's a different animal because they haven't gotten chemotherapy yet. And I think that's a lot easier to say I want to treat them like Z11. Because if they have a positive node after, they're still waiting for their chemo, they're still waiting for their radiotherapy. So why do I need to dissect them? I have trouble with that. I think that in those scenarios, I have managed them according to Z11. Personally, we don't have a defined policy, I don't think, at Memorial for that. But I think after all these endocrine therapy patients that we're treating, we might. But I don't see why you would dissect them when they're going to still get all the additional treatment that they would have in Z11.
Perfect. Thank you.
Are you enrolling patients for this randomized trials for pathological axillary response like Alliance or B51? We
were the primary accruers. We were the top enrollers in Alliance. So I enrolled as many patients as I could onto that trial. But but the problem is that most of the people that were node positive after chemo were ER positive. So we're just going to see a huge amount of patients enrolled on that trial that are hormone receptor positive. And, you know, our real interest are the triple negative and HER2 positive. And in B51, we enrolled as well. And so we have a fair number of patients who didn't have any RT after mastectomy or just had breast RT and no nodal RT if they achieved PCR in the nodes.
So is there any expectation for the primary results, 2024, 2025?
I don't know. Alliance closed to accrual. Well, they were on a temporary pause. They told us we couldn't enroll anymore while they were doing an analysis, and we haven't heard back. So we haven't been accruing for about 6 months onto Alliance.
Perfect. I have a question for Dr. Artur here from Guilherme Novita. Artur, don't you think that gene expression signature should be one kind of indication for radiotherapy, adjuvant radiotherapy after breast cancer?
I think they have to be. I think things are directing that way, but so far I'm not sure if anybody is using that. I've heard that some signature tests were designed for DCIS, like to stratify risk and try to better address indications for this kind of patients. But I'm sure we're going to have something maybe soon to better stratify risk in radiotherapy. But again, the difficulty about radiotherapy is that we have a very heterogeneous assessment in the kind of a treatment. We're talking about post-mastectomy RT for just the thoracic wall, or maybe whole breast radiation. It's a very homogeneous approach, but once you talk about nodal treatment, things get very, very complicated to interpret the results in a proper way.
Perfect.
Andrea, when you have a positive sentinel node, a positive lymph node, and you propose to this patient neoadjuvant chemotherapy, for instance, do you clip this lymph node?
So again, many patients come to us with a clipped lymph node. So the question is, do we localize the lymph node or try to retrieve it as part of our sentinel node procedure? We do not do that. The NCCN and St. Gallen says you have to try to do any method you can do to minimize the false negative rate, right? So that's either retrieving 3 or more sentinel nodes or retrieving the clipped node and another node, which is what MD Anderson does and a lot of places do, is that targeted axillary dissection. And I think whichever method you do to minimize the false negative rate is fine. What we have been doing to try to look at this, so we find 3 or more sentinel nodes. We're publishing our most updated data on over 600 patients that are node positive treated with neoadjuvant chemotherapy who became clinically node negative, just got accepted, and will be in print hopefully in a couple of weeks. We find 3 or more sentinel nodes 93% of the time. So it works for us. It's a successful way for us to omit axillary dissection. But we did find that mapping was not as good in patients who had a high BMI or who had lymphovascular invasion, either on their core biopsy or on final path. So we said maybe those are patients that we could consider trying to get the clipped node. We have been x-raying our nodes, though. So when we do our sentinel nodes, we x-ray them just to see if the clip is there, so that we can eventually do a publication, maybe saying what is the advantage of getting the clipped node if you already have 3 nodes. But again, the most important endpoint is not our false negative rate, it's local regional recurrence. And more to come on that. But we really want to know, are these patients failing? And we know that the rates of recurrence are far lower than false negative rates in general for axillary recurrence. So I think whatever strategy you employ is fine. For us, it's 3 or more nodes.
Let me ask you a question. Here in Brazil, not everybody has the dual tracer, okay?
Mm-hmm.
The technician is a problem in the public health system.
Mm-hmm.
Do you think we can try to localize the 3 lymph nodes just with blue pattern? This is the first question.
Mm-hmm.
The second one, if we don't get 3 lymph nodes, just 2 lymph nodes,
mm-hmm.
I must do a search for a lost lymph node. I have to stop where it marks. What do you think about it?
I think the identification rate is a lot lower with just blue dye. I think if your goal is to try to get 3 or more nodes, and I think dual tracer is optimal. But if you don't have dual tracer, then that's when you need the clipped node, right? You need something to kind of maximize your or minimize your false negative rate. But I don't think that single tracer alone is adequate. I think you need dual tracer. A palpable node is still a sentinel node, even if it doesn't have blue dye or technetium. And that's not cheating. It's real. When you do a sentinel node biopsy, you look for your blue nodes, you look for your hot nodes, and then you palpate the axilla to see what you find. If my blue, we inject the blue dye post neoadjuvant chemotherapy, and I give 5 cc's. I give all 5, and I do a 5-minute massage, and I wait and to see what uptake. And I can tell you, I've almost never had a situation in the N1 setting, so early disease, that I didn't find 3 nodes with this technique. And technically, if I only have 2 nodes, I'm supposed to do an axillary dissection, but now that we've been x-raying the nodes, if I got the clipped node, then I don't. So
you inject 5 cc?
5 of blue, yeah.
Everybody turns an avatar after a surgery.
Yes. I mean, you're paying for the whole bottle, so you might as well use it. Yeah, Dr. Morrow injects 10.
10?
Yes.
Oh, shit.
Yes. I do 5.
That's a lot. That's a lot.
And what about anaphylactic reactions? Do you have more than?
No, we don't have more. I mean, I think we have the typical, which is 0.5% anaphylactic. But we get blue hives, those things, but usually not anaphylaxis. I've had one patient, and it was about 3 years ago.
I have one question for Dr. Artur from Francisco Pimentel. What about your recommendations of adjuvant radiotherapy in a T2N1 post-mastectomy patient with a pathologic complete response after neoadjuvant chemotherapy? Do you recommend or not?
Yeah, I think I would that if you have some more information about that, if there's a triple negative or HER2, the age of the patient, has or not lymphovascular invasion, the grade of the disease. But usually I come from a school that an axillary node usually is at risk for relapse. And if this is a sentinel node biopsy, I will probably go for radiation. And depending on these other high risk features, probably to go for nodal radiation as well. Usually we were using in our department at least three risks, the presence of 3 prognostic risks to address more extended field radiation. But depending on what kind of surgery, if there was an axillary dissection or a sentinel node biopsy, the main discussion in the department is if we're going to go for the fields used in Z11 or in the Amaros trial. So a different kind of approach in regarding the extension of the nodal risk.
I have a very good question here for you both. From Dr. Josebinis. Do you think there will be changes in breast cancer local care that will remain due to the pandemic changes? Or after the pandemic finish, everything is going to be as we were used to do?
From a surgical perspective, I don't see what surgically we would change. I think, our whole goal in surgery over the past 15 years has been do less. How can we do less? So I don't think that that's going to change. I do think there might be changes in different approaches in either neoadjuvant or adjuvant therapy. I think one of the biggest changes for us may be our radiation therapy moving forward. Who to omit, lots more partial breast, like we talked about, and more hypofractionated dosing, but even in the setting of post-mastectomy radiotherapy. So I think we just have to wait and see about that. From the systemic therapy perspective, there may be a shift towards more neoadjuvant endocrine therapy, but I think that's been coming anyway. And I think as we learn more about genomic assays and helping to predict response, we're going to see that trend coming anyway.
I couldn't agree more with Andrea. I think that hypofractionation is going to come for good. When I'm talking about hypofractionation, just not the moderate approach, but even the fast forward with a weak approach. And this is a very, very elegant approach, even in a country that we have shortage of machines. And usually people have to travel long distances to treat. So you can either treat the whole fractionation in 1 week, or you can have 5 different weeks when the patient comes just once a week for treatment. So I think we might incorporate that. There are some issues regarding technology and some quality assurance protocols that needed to be used in order to safer treat these patients. But definitely, I think hypofractionation is going to come for good in breast cancer radiotherapy.
Even in regional setting, Arthur?
Even in regional setting, seeing the nodal hypofractionation radiation was a kind of a very, very uncomfortable approach when the Canadian and UK papers came out, because this population of patients were not very very well represented in the population. So from this past 2 or 3 years, since we've been treating lots of present breasts with hypofractionation, seeing that this is a very, very safe approach, people is moving for the regional using technology. So we have some papers coming out. There is a very, very nice talking about the Sunnybrook, the Toronto Sunnybrook experience in Canada, with measuring the trend. They use a hypofractionation from 2011 to 2018, and in 2016 they haven't done any patient with hypofractionation in the nodal areas. 2017, 33% of the nodal radiation was hypofractionated. In 2018, up to 76%. So in Canada, they're using much, much more. And even in Brazil, when you start doing that for 1 or 2 years, I'm actually talking with my colleagues. I'm seeing that everybody's getting more comfortable to this kind of approach. But the thing is, you need to have technology to better control the dose distribution in the nodal area. I'm myself doing for some patients.
Perfect. Well, I have a question here for Dr. Andrea again, from Daniele Carvalhais. If you have lymphoscintigraphy, pre-op lymphoscintigraphy, confirmed 3 lymph nodes marked with a radio tracer, can we omit the bullseye, or are you still doing the bullseye?
So, I mean, we just have a policy that we always do that we use dual tracer mapping, just because the false negative rate in the 4 prospective trials showed a reduction in the false negative rate with the use of dual tracer mapping. So it's just our policy to do it. Memorial's funny about lymphoscintigraphy, because at the main campus they use it, and then at the regional sites where we inject, they don't use it. So my patients do not come with lymphoscintigraphy, and I'm very happy about that. I think it's a waste of money. So, because I'm never going to go after an internal mammary node or So I think if you saw 3 and you knew you could reliably get it, I think it's fine. But again, most of the data shows us that we're going to decrease our false negative rate with dual tracer mapping.
You don't perform lymphocytography. You just inject and take it a few hours later to the ER? Is that so?
We inject the day before. That's when we put our seeds in. So we put the seed, we inject, everything's done the day before. And we have a neo probe that just confirms that the injection was good, that they actually injected into the breast and not lost the dose. And then they come to the OR the next day. Yeah. And I don't have a lymphosinogram.
Okay. I have another question for Dr. Andrea from Carol Souza. And if you apply in the AMAROS trial in young patients who have done mastectomy and has a unfavorable biology tumor. No, not that question. That's one.
Sorry, not this question. Which question am I answering?
No, it's you are doing the AMAROS trial, doing the AMAROS policy in young patients that make mastectomy and has unfavorable biology tumors.
So probably about 2 years ago now, we sat down and decided which patients with 1 to 2 positive nodes would our radiation oncologists always radiate. And because the one thing you don't want to do is an axillary dissection and nodal RT in a patient with limited nodal disease because their morbidity is so high. So we sat down, it was 7 long hours of debate, and all we really could come up with was triple negative and under 40. So our triple negative under 40 patients with 1 to 2 positive nodes, they will radiate every time. So if I have a young, but there are caveats to that. There are some patients who are under 40 that have, LVI and 1 to 2, 2 positive nodes or this. So if I have a question in the operating room and I only have 1 or 2 positive nodes and it's a very young patient with some other bad biology, I'm going to defer that axillary dissection until the final pathology and wait. And if they have limited nodal burden, then I will just tell her to go get radiated. We will treat those like AMAROS. Yeah.
Okay, Felipe, you can move on.
I have a question to Artur. Artur, if you have a patient with axillary positive patient, okay? You perform neoadjuvant chemotherapy. And when you try to do the sentinel node, you don't find the sentinel node. And not Andrea, she finds every time. Hélio does not find the sentinel node, so he performs an axillary dissection. And you have no positive nodes. You have 12 negative lymph nodes. But she had a positive lymph node pre-chemotherapy with a punction confirmed. Do you think it's necessary to irradiate this axilla if she performed axillary dissection, or you just irradiated the supraclavicular?
Usually we go for the extra field, like to cover the axilla with radiation only if you have extracapillary spread outside, in order to even in this kind of surgery that Hélio performed, we gotta ask that usually when you don't find the sentinel node biopsy, you don't go for level 3. Usually they go for level 1 or level 2. So we'll probably design the nodal fields to encompass the supraclav area and probably the apex, like the level 3. But I won't go for treatment in the level 2 and level 1. But using this question to provoke, I believe that the higher risk of lymphedema is present when you go for level 3 dissection. Usually when you don't resect the level 3, the rates of lymphedema are much lower. So I don't see in my clinic anymore those huge lymphedema arms that usually came from those very aggressive axillary dissections in patients with local advanced disease. There are some, but usually when you have positive nodes after surgery, after neoadjuvant chemotherapy, so you got to be more aggressive in the axilla. But I think this is gonna change in the future, because I believe the right approach will be when you balance the aggressiveness of a surgery and the benefit that you can have with radiation, enforcing the need of a multidisciplinary approach in breast cancer.
Andrea, do you advise some physiotherapy approach prior to surgery?
What do you mean? Like, do we teach them?
You know you have to do axillary dissection, okay?
Mm-hmm.
Do you send this patient to visit the physiotherapist prior to surgery, or no, just after the surgery?
Yeah, after. We have a booklet with exercises and has information. So New York State requires that we educate all patients having an axillary dissection about lymphedema. So they get educational material to read about it. And then on their first, if they stay, anybody who comes for surgery before COVID would have a physical therapist come see them. And teach them arm exercises, show them the exercises, and then also talk about hand and arm precautions.
Prior to surgery?
After. So right after surgery. Mm-hmm. Either the day after surgery if it was a mastectomy, or before they went home. We don't do that now. They just get information, and I don't know if we're going to end up making a video, which would end up being the best way to kind of.
Physiotherapy should be difficult.
Yes, yeah. I mean, we haven't really been doing that, right? No physiotherapy, and only for emergencies when patients really. I had a patient who was very young and developed lymphedema recently and couldn't close her hand. She was really having trouble, and so she had to come in, and they decided she was an emergency, so she got seen quickly.
Artur, do you have any policy about that at the radiotherapy facilities?
You mean for physical therapy? Yeah, usually we do when we receive a patient post-surgery. So there's some restriction in the arm abduction. So we usually send them for PTE before, just in order to have a comfortable position for radiation. Sometimes we have some more complicated cases. I had one just about 2 or 3 months ago where we had to wait for 8 weeks in order to have adequate position for the arm for radiation. So sometimes we have very, very bad cases.
Yeah.
Hélio,
yes, I have just one more question, I guess, here from our friend Valdair. Andrea, in memorial, do you use an axillary imaging post neoadjuvant chemotherapy before the surgery or not?
No, I mean, not directed. Some patients will have an MRI, so you can see what their nodes look like. But we don't do a directed axillary ultrasound to look at the nodes because it's not predictive of their response. Patients with abnormal nodes can have a PCR. Patients with normal nodes can have residual disease. So, even in ACOSOG Z1071, where they looked at that subset of patients, there was about 30% of patients who had abnormal axillary nodes that were node negative. And if you said, I'm going to do an axillary dissection on all those patients, you would have done an unnecessary axillary dissection. So I just don't think that will help you make a decision about treatment.
How do you follow up these patients, Andrea? Those that were node positive, they got negative with chemotherapy, then you perform the sentinel node, it came negative. Artur probably will do the radioterapia at the axilla.
Mm-hmm. He'll take care of the nodes.
Yeah. How do you follow them? Just physical examination, or do you perform any kind of axillary ultrasound? We
do not follow them with axillary ultrasound. So we just do annual mammography and bilateral screening ultrasound if they have dense breasts. That's it, but not directed axillary ultrasound. We do that with exam.
Just like the guidelines.
Mm-hmm.
Perfect.
Yeah, it's very nice to point out that the assessment of the staging assessment pre-chemotherapy or pre-surgery is very important for us in radiation departments in order to safer approach the volumes to be treated. I mean, usually people here in Brazil order lots of MRIs, like neoadjuvant chemotherapy, just to assess response. And those,
we do that too.
Yeah, those exams are very, very nice to help us to design the treatment fields after neoadjuvant chemotherapy and surgery. So we reinforce the approach, not only to assess the response in order to better address your surgery, but to help the radiotherapy after all these treatments.
We're not going to fight now that we're ending, Arthur? You don't have to propose that in the end of the discussion. Guys, do you have any question that you want to make us? Andrea, Arthur?
I would like to thank you again for the invitation. This is a very, very productive and deep scientific discussion that indeed is going to help everybody in order to face this pandemic, like trying to make us do better decisions with our patients. And this initiative from you guys is very, very, very nice. So thank you and congratulations for this very, very nice discussion tonight.
Yes, thank you so much.
Hélio?
Yes, thank you very much, Dr. Andrea, Arthur. It was a pleasure for us. It was a huge and amazing class for us. Everybody here is saying congratulations, thank you very much. So hope you get well at home and at your work, and hope to see you again soon. Thank you very much.
Thank you so
Andrea,
much.
Arthur, on behalf of all our staff of Câncer de Mama Brazil, we'd like to thank you. We got on time, just 7 minutes past 9 here in Brazil, and 7 minutes past 8 at New York. So you won't lose your dinner, Andrea. Thank you.
I won't. Thank you.
Much.
Be safe.
So much.
At San Antonio, if came San
I hope
Antonio
so.
this year. Yeah.
I hope so.
Be safe.
Thank you.
Thanks.
Thank
Bye-bye.
you.
Bye.